Pawan, sir, you can start, sir.
We all welcome you to this NESI webinar series 2. It's a monthly update which happens by the Neuroendoscopy Society every third Saturday. We are having it, and this time the coordination has been done by Professor Dandapani, and a very important topic which he has picked up about invasive pituitary adenomas. A very specific topic, good topic picked up by him, and with that, I request Dr. Dandapani to introduce Professor Gupta and start the meeting.
Thank you, Dr. Subodh, sir. We welcome you all for this webinar. To begin this, I would like to request Professor S.K. Gupta, Head of the Department of Neurosurgery, PGI MER, Chandigarh, to introduce the topic. And he needs no introduction to our audience. He has been an eminent skull-base surgeon, worldwide known for his extensive work in skull-base surgery. So I hand over to Professor Gupta, sir.
Good evening, everyone. And I'm thankful that you have asked me to introduce sort of this topic. I'll be brief. I was told by Dr. Dandapani, I think moderators are Dr. Subodh and Dr. Dandapani, and we have eminent panelists are Dr. Sankla, Manas is also not here, Dr. Ashish Patil and Dr. Junita. And we have eminent speakers, Dr. Pipagaran, Dr. Schwartz, Dr. Dandapani and Dr. Janki Ram. Am I right?
Yes, sir.
So I will just, the topic which was given, what should we look forward to in cavernous sinus intervention? So anything you want to progress, you have to look at the past. The surgery for cavernous sinus has progressed over the last 3-4 decades. You see, after the brief restriction of the cavernous sinus called sinus by Parkinson's, there have been so many eminent, daring surgeons who have ventured to enter into this territory, like extradural approach described by Winkle Dolling for clipping of the giant aneurysm, which of course we don't do at present. But these people who have laid the pioneer, they pioneered the entry and surgery of the cavernous sinus. Similarly, there was another gifted neurosurgeon who again needs no introduction, but many people sometimes somehow ignore him. So I think his name needs mention. Okuba was one of the most gifted neurosurgeons of his times and described approaches of skull-based approaches to the cavernous sinus. Similarly, we had Laligan Shekhar, of course. He ventured into the cavernous sinus by the extensive skull-based approaches, did monitoring of all the cranial nerves, and also taught us how to reconstruct the cranial nerves during surgery. Not many people have that skill to do it, but these are some of the people who pioneered and ventured into the cavernous sinus despite so many hurdles. Again, from Little Rock at present, Osama Al-Mefti, he described extradural as well as intradural approaches to cavernous sinus meningiomas, how to manipulate and control the carotid artery by different approaches. Then, not too distant, Alichrist described transcavernous approaches and how to manage the cavernous sinus, and through the cavernous sinus, how to clip the various aneurysms of the posterior circulation as well, and how to tame the cavernous sinus by reducing the venous bleeding by fibrin glue. So he also described the pretemporal transzygomatic. So why I'm going through this is that it is this surgery over cavernous has evolved over the period of times. It may not be at present, we may not be doing these things, but this is how it has evolved over the time. Meningiomas. Then we move on to endovascular. At present, hardly any neurosurgeon is doing open surgery for dural cavernous fistulas or aneurysms. Most of them are managed by endovascular management by interventional people. Endovascular management, cavernous and paraclinic. So they are not operating on these. They are mostly managed by flow diverters or other procedures. Then, of course, the endoscopic people, you people who have again revolutionized the approach to cavernous sinus, to endoscopic approach to the lateral wall of cavernous sinus, especially for anterior and anteroinferior lesions. They entry into the cavernous sinus for deroofing of the optic nerve. And then there's a transpterigoid endoscopic transvaral approach to the pituitary adenomas, which Dr. Dandapani will be talking about, extended endoscopic approaches. Then transpterigoid approaches to the cavernous sinus. Then recently, many people do. It is accepted that some tumors like cavernous and mangiomas, the standard of care is direct radiosurgery. Of course, we must be sure about the diagnosis. So this has become a standard of care, not surgery, but direct radiosurgery for cavernous and mangiomas if they are not big enough, and also for hemangiomas or cavernous sinus. I think Dr. Dandapani has recently treated a patient of cavernous sinus hemangioma with gamma knife radiosurgery. So when we move forward, we have to look at how it is evolved. So recently, there is more stress again back to anatomy by plastination and other techniques that are already described, and cranial nerve probabilistic tactography, knowing the cranial nerves where they are. So instead of trying to search them and monitor them intraoperatively, you should know preoperatively where these nerves are. And various techniques, imaging techniques have been described, like cranial nerve probabilistic tactography, and there is another technique, deterministic fiber tracking of the cranial nerves. So basically, the aim is to know which area is safe, which to enter, and how to save these cranial nerves. So you have options at present: surgical options, endovascular options, and radiation options, which may be transcranial, tendonasal. Endovascular may be transarterial or transvenous, depending on the location of the lesion, whether you want to go through the arterial route or through the ophthalmic vein or through the transpetrous vein. And radiation, of course, radiosurgery and radiotherapy. So with this brief introduction, how this earth is evolving and evolving, I will hand the mic and the session to the moderators. Thank you.
Thank you, Professor Gupta, for giving the lead on discussioning about cavernous sinus, invasive pituitaries or cavernous sinus involvement. I'll not take much time. We have our expert panelists. Dr. Suresh is there. Dr. Rajnita is there. So we will take because it's a common topic. I mean, all the topics are common. Can we take the questions at the end after each of the speakers? Because
I think, yeah, I think, let us have the lectures and then have the questions.
Yes.
So that, we'll, not only will save time, but,
yeah,
we'll have a better discussion also.
Absolutely. Thank you. With this, I'll invite our next speaker, Professor Narayanan. He works in UM Specialist Center in Kuala Lumpur, Malaysia. And we have heard him before, actually. His excellent talks on skull-base surgery. It may be, and also otology and cochlear implant. And he has been appointed as a president in the 9th World Congress of Endoscopic Surgery of Skull-Base, Brain and Spine 2020. He has numerous publications, peer-reviewed articles and books in this, and he trains a lot of people in skull-base surgery across the world, and he travels extensively to give his lectures and conducts workshops. With these few words, I'll request Professor Narayanan to take.
Thank you so much for the very kind introduction. So allow me to share my screen. Can you see this?
Yeah, we can see it.
Okay, thank you very much. So I would like to speak.
Yeah.
Sorry again. I would like to speak on cavernous sinus and related anatomy, endoscopic transnasal surgery. So basically, I'm going to start with comparing the anatomy that we get with an open craniotomy and an endoscopic transnasal. So the cavernous sinus itself is just a piece in a large jigsaw puzzle. So for us to understand the surgery of the cavernous sinus, we need to understand the other relationships of the Meckel's cave, petrous apex carotid artery, the infratemporal fossa, and then I'll go on to some clinical cases of the cavernous sinus, the Meckel's cave, and the petrous apex as well. So this is a view that that the entire jigsaw puzzle itself, and you can see how extensive the jigsaw puzzle is. The cavernous sinus itself is only this portion, just here. So if you look at the cavernous sinus, it's actually a small piece of jigsaw puzzle in the entire jigsaw puzzle. So let's look at the anatomy one by one. That will be the inner ear. This will be the cerebellum and the brainstem. That will be the basilar artery. So this will be the third nerve here. And this will be the fourth nerve, the nerve that comes behind the brainstem, going down its here. And this would probably be the fifth nerve here, as you can see. This would be the horizontal portion of the petrous artery, the vertical portion, the paraclival portion before it becomes the carotid siphon here, as you can see. So now we go a bit closer, and then we are able to visualize again the Meckel's cave. the fifth nerve. This is the V1 that goes into the cavernous sinus, the V2. So this is the lateral wall of the cavernous sinus, and the cavernous sinus per se is medial to it. This will be the foramen ovale, this will be the foramen rotundum. And again, if we have a much closer view, this would be the fifth nerve, the Meckel's cave, V1. That's the fourth cranial nerve that's coming from the back of the brainstem. That's the third cranial nerve. That's the V1, V2. This forms the boundary of the lateral aspect of the cavernous sinus, with the cavernous sinus actually being medial to it. So if you come from the top, this is the view that you would get. And again, you can see how the V3, the foramen ovale, it goes into the anterior and the posterior branch between the two lateral hits of the pterygoid into the infratemporal fossa itself. And that's the V2. And this is the foramen rotundum here. That's the foramen ovale. So with this view, I will give the same view now from the endoscopic approach as well. Yeah. So let's look at the endoscopic dissection of the cavernous sinus. Before that, let's look at the entire endoscopic skull base so that we appreciate the anatomy. This is a patient who had a extensive sinonasal malignancy, also recurrent. After removing the tumor, this is the anatomy that we get. So that's the anterior cranial fossa dura. That is the orbit that is being compressed. If you follow the orbit backwards, that's the dura, as you can see, that is being completely exposed. And this is the optic nerve. There's a junction between the optic nerve and the dura that you can see very nicely here. And this again is the optico-carotid recess. That's the carotid siphon. This is the tubercle. This is the planum, the clivus. And this is the optic, so this is the cavernous sinus. That's the paraclival carotid. And this will be where the cavernous sinus will be. The paraclival carotid, the cavernous sinus in this view here. So that gives us, and that is the V2. This is the infraorbital, the V2 in the cavernous, before it enters the cavernous sinus, and the Meckel's cave will be down here. So this gives us an overview of the anatomy, the skull base itself. Let me show you step by step of the dissection of the anatomy in the skull base. Again, as I said before, it's a cavernous sinus. It's just a piece, the large jigsaw puzzle. And what we are going to do is we are going to go from distal endoscopic anatomy, and we're going to go layer by layer proximally until we go into the brainstem. So let's start with a review of the infratemporal fossa, which is where the V3s and the V2 are. This is the orbit, as you can see, the middle rectus muscle and the inferior rectus muscle. This is an endoscopic view. And again, this is the infraorbital nerve of the V2. And if you follow the orbit backwards, it takes us to the optic nerve, where the optic chiasma is, and that's the carotid artery. So this is the maxillary artery with the sphenopalatine artery. And that's the descending palatine artery, as you can see here. And then if we push this down, that's the maxillary artery. And this is the descending palatine artery, as you can see. But the most important part is the V2. So if you follow the V2 backwards, you come to the foramen rotundum. That's the median nerve. And if you follow the median nerve, it takes us direct to the internal carotid artery. Very nicely seen, the median nerve, the opening of the median nerve canal, as well as the foramen rotundum. This is the paraclival, therefore the Meckel's cave would be here, the paraclival carotid, and the carotid and the cavernous sinus would be at this portion here. Now, let's look at where the foramen ovale would be. Again, this is the infraorbital nerve, as you can see. If you follow it backwards, it takes you to the foramen rotundum. That's very nicely seen here. And this is the median nerve. The junction between the foramen foramen rotundum and the median nerve is where the pneumatization of the lateral recess of the sphenoid would be. And this is the maxillary artery. And if we dissect the muscles of the lateral pterygoid from the lateral pterygoid and the lateral pterygoid, you'll be able to identify the V3. So that is foramen ovale, and there's the V3 with the anterior and the posterior branch. That's the posterior branch, and it gives you, it goes into the lingual nerve, the inferior auricular and auriculotemporal nerve, into the two heads of the lateral pterygoid. That's beautifully seen, the V3 here. So in the same way now, let's follow V2 and V3 backwards to the Meckel's cave. Again, you can see there's a foramen rotundum, and if you pull the nerve, you can see the movement of the Meckel's cave. Follow the V2, it takes you straight to the Meckel's cave here. And that's the foramen ovale that's been dissected out. That's the dura of the temporal bone. That's the foramen ovale that has been drilled out, giving you both the anterior and the posterior branch of the V3 itself. Now, let's look at V2, V3, and the ICA of the petrous apex in relationship to the carotid artery. So if you follow this back again, that's the V3. And now we can see the paraclival carotid. that's the siphon. And if you dissect the siphon medially, lateral to the siphon, this is where the cavernous sinus would be. And if you follow the carotid artery backwards, this is the petrous apex, and that's the horizontal portion of the carotid artery, and this is the vertical portion of the carotid artery. So with this, we have all the jigsaw puzzles into place. And now let's look at the cavernous sinus itself. So again, if you look closer to the cavernous sinus, it's always lateral to the paraclival carotid. And here you can see the sixth cranial nerve that runs inside the cavernous sinus, the V1, V2, and the V3 is usually outside the cavernous sinus itself. Go a bit closer, that's the V3, sorry, that's the third cranial nerve. There's the fourth cranial nerve, that's usually quite small. The V1, V2 that forms the lateral wall of the cavernous sinus. And another dissection view, the sixth nerve that runs inside, the V1, V2, and the V3. This goes to foramen rotundum. This goes to foramen ovale that has been drilled out. So this is another dissection of the cavernous sinus itself. This is the right side. That's the paraclival carotid and the siphon. And if we dissect the carotid siphon away, we are now into the cavernous sinus proper itself. So this would be the sixth cranial nerve that's free floating. And the largest nerve will be the third cranial nerve here. And the fourth cranial nerve is usually very difficult to see because it's lateral and it's quite small. And then when you go lower down, you'll be able to see V1, that's V1, and that's V2 along the lateral aspect of the cavernous sinus. That's V1 nicely seen, and the V2 as well. So this forms the cavernous sinus as it is. Let's go now into the origin of these nerves intracranially. So this is a transclival. That is the basilar artery, and this is the posterior cerebral, superior cerebellar, and between these two is the third cranial nerve, as you can see. And then by using a 30-degree scope, if we rotate, we can see the fourth cranial nerve, the longest intracranial nerve that comes from the posterior part of the brainstem, the fourth cranial nerve, and this is the fifth cranial nerve, and this is the sixth cranial nerve here. And there's a 7 and 8 complex, as you can see. So again, the sixth cranial nerve, there's the fifth cranial nerve, and the 7 and 8 complex as it goes into the internal auditory meatus. And then if you go and rotate, that is the 9, 10, 11 complex down here. And here we can see the basilar artery and the vertebral arteries, as you can see. So again, we need to imagine that's the vertebral artery, the brainstem, with the 9, 10, 11 complex as well. So we need to imagine that the third nerve, the fourth nerve, V1, V2, all meets together into the cavernous sinus. Let's look at some cases. So this is someone who's got a lesion in the cavernous sinus. And I remember she came with a third nerve palsy. So you can see the scan shows very nicely the lesions in the cavernous sinus. So what we do is, first of all, we infiltrate the septum. We elevate the septal flap, make an opening in the posterior wall of the septum so that we have a septectomy, and open up the sphenoid keel, remove the turbinate on one side, until we are able to identify the sphenoid keel. And once we've opened the sphenoid keel, we open up the posterior ethmoids as well so that we are able to enter the lateral aspect of the sphenoid itself so that we are able to visualize the cavernous sinus portion. So now, this is the paraclival carotid on the right side, paraclival carotid on the left. That's the optical carotical recess. And this is the bulge of the lesion over the cavernous sinus itself. So what we're going to do now, we are now going to remove the bone over the lesion over the cavernous sinus, remove them with a Carrison punch, dissect until the lesion is exposed all the way to the junction of the paraclival carotid. The next step would be to make a dual incision to enter into the cavernous sinus itself. Now, this is the tricky part because if we are lucky, the cavernous sinus might be thrombosed, you won't have bleeding. But when you enter the plane between the cavernous sinus wall and the tumor itself, we would literally decompress the cavernous sinus. So what you would have, that's the tumor being exposed. And as we dissect and enter the cavernous sinus, this is the kind of bleeding that you can expect because the tumor has been decompressed. And then you start having quite substantial and significant bleeding from the cavernous sinus. This is something that you have to expect. Then what we're trying to do now is Vicky and I, my neurosurgeon and I, we're trying to find the plane between the tumor and the middle wall of the cavernous sinus so that we can actually put some Surgicel inside. So we tried to find the plane in between, and put some Surgicel. It wasn't successful simply because we were not able to get the plane in between, because the planes were stuck, the middle wall, and therefore the bleeding just became significantly worse. So what we decided to do was we used FlowSeal. We usually do not use FlowSeal because of cost. Again, by using FlowSeal, we need to identify the exact space between the cavernous sinus tumor and the middle aspect of the wall of the cavernous sinus. Place FlowSeal on top of it and push into the FlowSeal into the space between the tumor and the middle aspect of the cavernous sinus. And then once we are able to stop the bleeding, then we start dissecting the tumor out. So again, you can see this is like an underwater surgery because you'll have continuous bleed from the cavernous sinus. There's a tumor that's being dissected. Every time we decompress the tumor and dissect the tumor out, we have more and more bleeding, as you can see. Now, this is now a four-handed technique. I'm holding the scope and I'm holding this instrument. Vicky, my neurosurgeon, now is dissecting the tumor from the radial aspect of the cavernous sinus. So we need to hold, and as we dissect the tumor out, we are actually decompressing the cavernous sinus. And you can see the kind of bleeding that you will have from cavernous sinus as we decompress it. Again, by using a FlowSeal, push a patty into the space middle aspect, and then we dissect the tumor away from inside the cavernous sinus itself. I go a bit quickly in view of time. And now the tumor is being dissected. We're coming close to the lateral wall, and the tumor is being dissected from the cavernous sinus. So now we get a good grip of a tumor, and once we're able to dissect, we're able to deliver the tumor out, as you can see, and then dissect the tumor from the surrounding structure. So all this is done after the tumor has been dissected, and you can see some attachments to the inner aspect and the lateral wall as well. So that is dissected very clearly until the tumor is completely removed, as you can see here. And then we stop the bleeding inside by using a Surgicel. And this is the final view, the turbinate that is preserved on both sides so that the function of the nose is still preserved. And then the septal flap, which we never use, that's the paraclival carotid on the right side, the pituitary gland, that's the paraclival carotid on the left side here. And now we just filled up the space of where the tumor was by Surgicel, and the bleeding has stopped very nicely. She had a transient sixth nerve palsy, that's a paraclival carotid. She had a transient sixth nerve palsy, but both the third nerve and the sixth nerve recovered after 6 weeks after the operation. And the biopsy came back as an hemangioma. And if we had known it was an hemangioma, we may not have been so adventurous in removing an hemangioma in the cavernous sinus. That probably explains the kind of bleeding that we had. And this is how the patient looks like around 6 months down the line. You can see how everything has healed. That is the pituitary gland, that is the carotid artery, and this is the area of surgery where everything has healed very nicely. So let me go on to a patient who's got a V3 schwannoma. So again, you can see the septal flap that we raised that we did not use, the paraclival carotid on the right side, that's the pituitary gland, and that's the paraclival carotid on the left side. And this is where we are going to now give the exposure by dissecting between the V2 and the V3. We're going to remove the bone over the bulge, over the lateral aspect of the cavernous sinus. The tumor is actually going into the some part of the cavernous sinus as well. And now we are going to go and open up the cavernous sinus itself, or the lateral aspect of the cavernous sinus, and start debulking the tumor. So I'm going to go a little bit quickly in view of time. And let me go on, open up the dura a little bit more. And now we're going to dissect the tumor from inside. You can already see the lateral wall of the cavernous sinus. This is the paraclival carotid, and the tumor is being dissected. This is the lateral wall of the cavernous sinus, as you can see. The tumor is being dissected in a piecemeal manner. Again, by using 3 instruments. I'm holding this, and Vicky is holding the suction and the dissector in his hands. I'll go a bit quickly. Now we are going into the cavernous sinus portion itself. That's the lateral wall, and we are now able to go deeper into the cavernous sinus portion, and there's a carotid artery. That's the carotid artery inside the cavernous sinus itself. That's the lateral wall of the cavernous sinus. And now we are removing the tumor right at a depth, which is just medial or lateral to the carotid artery, and removing in a piecemeal manner, as you can see. The lateral wall, the carotid artery, and inside the cavernous sinus itself, we are removing it in a piecemeal manner, and removing the anterior portion, and removing the last few pieces from the depth of the cavernous sinus next to the carotid artery, and as the lateral wall has been dissected. So this is a very nice example of how two surgeons work together by using a four-handed technique. And this is my sucker to push the lateral wall away, and Vicky is dissecting and removing the final piece of tumor as well. So this is the final view after the surgery is done. You can see the paraclival carotid here on the left side, and then we have dissected all the way here, and then that's the lateral wall of the cavernous sinus, and that is the carotid artery inside the cavernous sinus itself, as you can see. So this is how the patient looks like a few months after surgery. Do I still have time, or should I stop here?
Full time.
Do I still have time, or should I stop here?
The time is over.
Okay, then I'll stop here then. Thank
Yeah.
you so much for having me to give this lecture.
Sorry for stopping you.
No, it's my pleasure. I understand.
Yeah. So it was some few interesting cases demonstration. I think the more we see these videos and workshop, we get more and more clear about the anatomy of the cavernous sinus. With not taking much time, I'll invite our next speaker, Professor Theodor Schwartz. Good morning to you.
Good morning.
Evening. Good morning. Okay. I mean, his CV is very, very interesting. He's presently working, and most of his career he spent in Weill Cornell Medical College, New York, and where he's currently a professor of neurosurgery, otolaryngology, and neurosciences. I mean, that's a very interesting professor, because we'll not have it in India that way. And the combination, his interest is skull base and, of course, epilepsy surgery. He has published numerous articles in different journals, and he provided commentary for numerous television shows in ABC, NBC, CBS, and Larry King, in addition to national radio. And his expertise has been sought through interviews quoted and published in Wall Street Journal also, and has been awarded America's Best Doctor and America's Best Doctors for Cancer. And he's a co-author of 6 books on endoscopic skull base and pituitary surgery, as well as textbooks on imaging and techniques for central nervous system. And today he'll be speaking on endoscopy for cavernous sinus lesion. Welcome, Professor Schwartz. Over to you.
Thank you very much. It's really a pleasure to be here. I have, as you know, my whole adventure into endoscopic surgery started with my collaboration with Vijay Anand, who's a ENT from Madras. So I am very appreciative of the entire continent and country of India that has helped me enter this field. So it's really a pleasure to be here. I also want to specifically thank Dr. Dandapani, who invited me, for his gracious invitation. And without further ado, I'm just going to dive into it. So I was asked to speak about endonasal approaches to cavernous sinus for non-adenomatous pathology. And so I'm not going to talk about pituitary adenomas at all, which is probably the primary reason that I would operate in the cavernous sinus, but we've had the opportunity to do similar surgeries for non-adenomatous pathology over the last 20 years or so. And here I work out of Cornell, New York Presbyterian Hospital, and started this, it's an institute really on paper between myself and Vijay Anand. As you have all mentioned, when operating in the cavernous sinus, you really have to balance the extent of resection question with quality of life question. And a lot of the time for firm tumors, meningiomas, we're really not going into the cavernous sinus to take out these tumors because the risks outweigh the benefits. We do have stereotactic radiosurgery used as a backup. So when we see cases like this, we may want to remove the top part of the tumor to get the tumor away from the optic nerve, make a definitive diagnosis. But we're going to leave this alone, and we're going to leave the tumor alone in the cavernous sinus and probably save that for radiosurgery. You've seen beautiful demonstrations of the anatomy, so I don't really need to go over that in any great detail, except to emphasize the fact that most of the cranial nerves, except for 6, lie in the lateral wall of the cavernous sinus. And any pathology that starts in the midline and pushes the carotid over is really going to push most of the important structures in the cavernous sinus over. And that's going to give us a window coming in endonasally. Now, I'm also going to talk at the end of my lecture a bit about a lateral approach that is not a craniotomy, but is another minimally invasive approach to get us to the cavernous sinus using the orbit as a corridor, which I think is important, and I think is going to be increasingly important over time. So this is just Roten's dissection of the anatomy. You know, you've seen the other one, but I just love to go over it a little bit more. But when we're coming in from the midline, obviously the siphon is going to be in our way. And we're going to see this bump here laterally where we're going to find V2. Above it is the supraorbital fissure. But we really want to be working in this location lateral to the carotid artery. You know, pituitaries, they're usually medial to the carotid. Here we're going to go lateral, although there is a way into the cavernous sinus this way. And I'll show you some dissections of that. Excuse me, I have a little cough. This is, once you remove the bone, you do see the cavernous sinus pretty clearly medially. You see you can have great access. You do have to do a transpterygoidal approach. So often we're opening up the back wall of the maxillary sinus. We're medializing the pterygopalatine fossa to get access to this area. This was a paper that Capabianca and Cavallo published talking about this medial corridor behind the siphon where you're going to see the third nerve, and very far back you'll see the fourth nerve. And then he'll show you a lateral corridor. And he has defined this sort of S-shaped structure made up of the third cranial nerve, the sixth cranial nerve, and V2. V1 lies in between that. This is where the heads off into the supraorbital fissure. And down here you see the bleeding nerve. So this is the endonasal view. If you go in this direction, you kind of get to the petrous apex. We're not going to talk about that. This is the cavernous sinus, of course. And here's Meckel's cave. I will talk a little bit about Meckel's cave at the end, but I'm trying to focus mostly on the cavernous sinus. So I'm going to talk about some cases that you can approach in sort of a graded fashion, right? So this is a case where a patient has a cranial neuropathy. There's something in the cavernous sinus. We have no idea what this lesion is. So the goal that I was assigned was really just to get a biopsy. And so I thought I could go endonasally. But as you can see, you know, there's a lot of hyperintensity around this lesion. There's going to be some cavernous sinus that's viable in the way. So this was a earlier case that we did where we said, this is a reasonable first case to go into the cavernous sinus. You take off all the bone over the carotid and cavernous sinus, use a Doppler, you figure out where the carotid artery is, and you go just lateral to that. And of course, there is the venous bleeding that we heard about, and that's all going to depend on how much of the tumor is effacing the contents of the cavernous sinus, whether it's in or just outside. But our goal here really is just to get a biopsy. So we put in a little pituitary, we grab a couple of pieces, just enough to know what this is. So this is sort of the least work you would want to do in the cavernous sinus. You're not trying to remove an entire tumor. But knowing that it's I think in this case she had a lymphoma, we could then go on and treat her. This next case that we did, and again, this is probably 18 years ago, was this lesion that was pushing the cavernous sinus laterally. We didn't really know what it was. I have the original video, and that's an older video, but it still shows the story. We opened up, we debulked the tumor laterally, and here, this was one of the first times I was trying to work in the cavernous sinus, and this was a cavernous hemangioma, similar to the tumor that was taken out by the other surgeon earlier. But here, instead of working laterally, we're working medially to the carotid because it faces medially. And here, we're trying to gain our confidence in our dural opening with the Doppler to realize, if we have to open up the dura all the way over to the carotid, and we really weren't comfortable doing that early in our experience. But these are the kinds of cases where you increase your ability and your competence and your confidence to open as close as possible to the carotid and work in that area. And obviously, we're just kind of rolling the tumor out because it is so vascular. You see, we've got thrombin-soaked gel foam We do use flow seal. We're lucky in the United States to have access to that whenever we want. It's incredible to imagine not having that, but we were able to get a, excuse me, gross total resection of this cavernous hemangioma. Now, chondrosarcomas go into the cavernous sinus more frequently. That's a pathology. I've seen that quite a bit. And this is a great example of how a tumor that starts medially will really push the carotid laterally. You can see how the carotid is lateral. You can see there's a corridor going right into the tumor from the sphenoid sinus. There's no reason to come at this laterally where you can face all the cranial nerves. So this is a great case to do that way. Here we're opening up the dura over the cavernous sinus and the pituitary gland. We're using an angled endoscope, angled suctions to remove that tumor. Medial and lateral, there's the carotid siphon, and we're sucking out the tumor on both sides to make sure we get the whole thing out. We have a 45-degree scope that we're moving around. And post-op, we were able to get the tumor out. But you can see there's this medial to the carotid is the larger area, but also we went lateral to the carotid here to get this little bit. And that really helped us. And chondrosarcomas respond well to radiation. And so, it's nice to get the whole thing out, but it's not required. This is just another example of a chondrosarcoma, cavernous sinus with a great medial corridor that allowed us to get it out. Now, this one was a little trickier because this patient had a calcified chondrosarcoma in the cavernous sinus. He was told it was unresectable, so he already had radiation therapy. He was developing a progressive third nerve palsy, so it came to us with obviously a much more difficult tumor. It's not been soft. There's been radiation given, and I actually have the original video from this. It's also some 15 years old. But so we're opening up the bone over the cavernous sinus, over the tumor. And the tumor itself is actually fairly calcified. You can see the rim of the calcified tumor that starts to move independently. The carotid is pretty far lateral here. So in order to get this out safely, we needed to internally decompress it. We're opening the bone over the siphon, which I do with a kerosene once you get in that plane. And then, you can see the tumor sort of has its own mobile shell, but we don't want to just pop the whole thing out. So we start drilling it down. First, there's some soft parts, there's some more firm parts. And as we drill it down more, it starts to fracture. And that allows us to take out little bits of it. But what we were afraid of is just yanking the whole thing out at once because the whole shell was sort of mobile. We didn't want to blindly just pull on it. So we used a bone curette and kind of shaved it down on the inside. You can see some CSF there. We did intrathecal fluorescein. And then we start to mobilize parts of the capsule. I thought that was a little longer, but not. Anyway, we got the whole thing out for the most part. We worked outside the capsule, and she did well. This was a chordoma that invaded, excuse me, into the cavernous sinus. You can see it doesn't have much invasion on one side, but on the other side, not only is invading, but it's compressing that carotid artery. And this is a case where if it's very firm and fibrous, as this chordoma is, we're probably not going to get the whole tumor out. But we are able to debulk quite a bit of the tumor. Unfortunately, I don't have the video of this, but I have the post-op MRI scan. And then she went on to get proton beam, and this is her 6 months after her proton beam. And it's a pretty good outcome for that chordoma, which may at some point come back because it's unlikely we got 100% of that tumor out in the cavernous sinus, but it certainly looks very clean. This is a dermoid in the cavernous sinus, which we presented itself to the sphenoid sinus. This is a woman who came to me in 2013 with double vision. I told her I thought the best approach initially at the time for me was to go into the cavernous sinus. You can see there's a window right here. I always try to see what the window is, where the carotid is, where the lesion is, make sure there's a window for me to get into it. Lateral to the carotid, hopefully it's about 1 centimeter of bone that I can remove to get in there. So this is the video of her surgery. We're taking off the tumor off the cavernous sinus endonasally. This video is a little jumpy. I apologize. Here we go. So we're opening up into the tumor of the cavernous sinus. Now it's a dermoid, so we just need to decompress the contents the wall of the dermoid is stuck to the cranial nerves, and we didn't think we could get 100% of this tumor out. You can see as we evacuate the contents, you do get a little more bleeding. I think it'll smooth out in a minute, give you a better view. So this here, we're looking into the cavernous sinus, into the dermoid with the endoscope. We're not able to get the wall off. But you can see post-op, we were evacuated the whole contents. And she did great. And here's the trajectory we took into there. She did great for about 7 years, and I'll show you what her recurrence looked like and how we handled that. But for a minute, I do want to show you a Meckel's cave schwannoma, because I'm going to talk a little bit about schwannomas. This is one that is not in the cavernous sinus per se, but has a similar approach. And we wrote this paper. This is a tumor that's really in Meckel's cave, and I'll show you here how we can get in there. So we do a transpterygoidal approach. That's the maxillary sinus. We sweep over the contents of the pterygopalatine and fossa. We remove the pterygoid bone, get access laterally, and then we can see this lump lateral to the carotid, right? The carotid is medial, and the tumor presents itself lateral to the carotid. Excuse me. So we take off the bone, open up over the tumor. And there you can see the two walls of the cavernous sinus opening a little bit with some bleeding. But the tumor is soft and suckable, so we can go in and remove it using standard endovascular techniques. And it's an extradural surgery, which is what's great about this. So this patient can go home the next day. It's a post-op. We did have a flap available in case there was a leak, but there wasn't. Now then we tried this trigeminal schwannoma, which is a little bigger. And post-operatively, we had left a little bit because to get there, we had to come in lateral to the carotid. So this is our trajectory. And then making this angle was very difficult at the bottom of the deep cavity. So we couldn't get this last little bit out. And so I started to think about these approaches. The subtemporal approach, there's a lot of brain attraction to get a tumor like this out. The endonasal, you're not down the long axis of the tumor. But I started to think more about this transorbital approach, and went to a meeting in South Korea where Dusik Kong was speaking. And he really convinced me that this was the best way to get to the cavernous sinus from a lateral approach, and to Meckel's cave from a lateral approach. And he showed me this video, which shows the anatomy beautifully. If you work around the orbit and you move the greater wing of the sphenoid, and then move the temporal lobe over just a little bit, with your standard approach that you do to a craniotomy, but with this angle, you get a beautiful view of the lateral wall of the cavernous sinus and Meckel's cave. You just have to get comfortable working your way around the orbit. You can also get to the petrous apex, as you can see more posteriorly. So this was the first trigeminal schwannoma we did the transorbital approach. I'm just going to show you, here we took the lateral rim of the orbit, dissected it over, and then you have to drill out quite a bit of the sphenoid bone, and it's standard endoscopic technique. Once you drill out the sphenoid bone to give yourself some room, you get to the middle fossa dura, and then you'll see the meningoorbital band. You have to cut that. And then you can sweep the middle fossa dura off the orbit and then off Meckel's cave. And then you can get right into Meckel's cave through this corridor. And here's the tumor. So extradurally, approaching it head on now, instead of medial to the carotid, we're approaching it lateral to the carotid, down its long axis, scooping out the tumor, and you'll see we can go all the way back to the posterior fossa. Now we can see the tumor that's going into the posterior fossa. You can see just a glimpse of brainstem, cranial nerves down there. And then as we remove the tumor completely, you see the trigeminal nerves splayed out medially and preserved, and the middle fossa dura laterally. We close with a button closure, and to see put the orbital limb back. So there's the post-op scan. Nice gross total resection of the tumor. You can see the corridor we took post-op T2. So here's that dermoid that came back 7 years later now. She presented with diplopia since we hadn't removed the capsule. So we got her 7 years. And they're no longer with the tumor presenting itself to the medial wall to the sphenoid sinus. So we didn't want to go back in that way. But the transorbital approach was a great option. So this just shows you how that approach works, drilling out the greater wing of the sphenoid, revealing the middle fossa dura, using a kerosene to go all the way to the supraorbital fissure with that removal, and then cut your new orbital band. Here we took off the lesser wing of the sphenoid. You can see some of the frontal lobe bone is also, frontal lobe dura is exposed above. New orbital band. Cauterized cut. Sweep the middle fossa dura off. There's a plane, natural plane there to expose the lateral wall of cavernous sinus. Here's a little more new orbital band. And then we get into the lateral wall of the cavernous sinus. And there's the dermoid. And we can get in again. We're not going to try to remove the entire wall. I just think that'd be too dangerous. It's going to be stuck to all the cranial nerves. We really want to improve her cranial neuropathy. It's a benign tumor. So hopefully we got her another 7 years at least. With this, her cranial neuropathy resolves with that button closure with some disc-seal. And then the orbit, falls, and you don't get a CSF loop in these cases. Just showing you the bone that we removed here. And the post-op with the drainage of the lesion. This was a larger schwannoma in the, it's somewhat lateral to the cavernous sinus, but it's in the same general idea. We did transorbitally. Such a big tumor, though, probably might have been a third nerve schwannoma, I'm not really sure. Honestly, she had a frozen globe. We did a lot of this with the microscope because it was such a big tumor. We were tracking the orbit, remove the bone, take out most of the tumor. But in order to really get deep into the necklace cave, you do have to use an endoscope. So we put an endoscope in at the end and took out the rest of the tumor. It's obviously a tumor that lends itself to this type of surgery. We're just sort of sucking it out, using angled suctions to try to get as much of it out as we can. All extradural. And so post-op, she did great. She was thrilled and went pretty fast. So in conclusion, the endoscope can be used to access the cavernous sinus either through the endonasal or transorbital route. Always keep in mind the goals of surgery, whether SOS can be used to treat any residual to avoid any unnecessary morbidity. Thank you very much.
Thank you very much, Professor Schwartz. First of all, for nice video demonstrations of the cavernous sinus lesion and finishing in time.
With respect to, yeah, you're welcome. With respect to questions, I actually have to leave and catch an airplane. I'm going to a wedding this morning.
Okay,
so
you want to?
It would be better to do questions now rather than later.
Okay.
Sorry about my cough.
Yeah, Professor Shankla and Dr. Ashish and Dr. Rajendra, if you have any questions from the panel to Professor Schwartz because he has to leave, please put it on. Then after that we'll take Dr. Dandapani's talk.
Thank you very much for your very well illustrated talk, and we enjoyed it. The situation where you decide to go straight away for radiosurgery or alternative treatment, are there any specific conditions where you will think that you would straight away decide, and what are the factors which help you to make that sort of decision?
Yeah. So obviously, if the tumor's a meningioma, meningioma in the cavernous sinus, we do try to do just radiation. We can now do this, what's called a dodicate PET scan, which will give us the diagnosis. So we don't really need tissue. Right. The times I'll do surgery is if I feel I can make the radiation safer by either getting the tumor farther away from the optic nerve safely or away from the pituitary gland even, move the pituitary, make the space there. And I will consider doing some sort of a minimally invasive surgery if I can. And I talked to the radiation folks and I say, would it be helpful to you if I could get this part of the tumor out or that part of the tumor out? And that conversation will push me. They may say, no, we're going to fractionate it anyway. We don't need it. So then I'll say, you don't need surgery.
Right.
So it's usually in meningiomas where, we know the diagnosis, we can make it with a go-to-tape PET, 100% certainty. And there's no reason to get tissue where we'll just avoid surgery altogether.
Great. Has there been any situation where you have injured one of the major vessels? I mean, have you come across that sort of situation?
Yeah, I mean, mostly endonasally, we've had some carotid injuries more early in our experience. Once when I was drilling with a cutting burr and not a diamond burr. So I very strongly recommend if you're in the sphenoid sinus, you switch to a diamond burr and not a cutting burr because you can very easily damage the carotid. Once when I've actually had a situation in acromegaly where the carotid was so thick and scarred and that I wasn't sure what it was. And I actually put a little needle into it and, it clearly was the carotid, but we were able to put some thick glue, bio glue over it to close the hole. So we didn't have to do anything else. But we've had rare carotid injuries. And in recent times, we really haven't. We've gotten pretty, safe, better at working around the carotid, so we haven't seen them.
Thank you very much.
Yes.
Can I ask a question to Professor Schwartz? Excellent demonstration of surgical techniques in many of these videos which you have shown. I would like to have your views on the recurrent chordomas. How frequently you advocate very aggressive surgery in recurrent chordomas versus the newer adjuvant methods like proton beam therapies and others?
Well, if we're seeing a chordoma that's recurrent, they've already gotten proton beam. Everybody gets, most people get proton beam, at least patients that I've seen, many do. The current chordomas are very hard because once they've gotten surgery and proton beam, there's a lot of scarring. It's hard to get a gross total resection. You just try to figure out how can I get out as much tumor as possible safely, what trajectory is going to get me there. If I have to do 2 surgeries from different trajectories, I would do that rather than pushing one. We don't see a ton at Cornell. We see, probably done maybe 20 chordomas in 20 years. There are other centers in the US that do more chordomas than we do. But when we see them, obviously, we take care of them. I haven't seen that many recurrent ones. Most of the ones I see are newly diagnosed, to be honest with you. Yeah.
Thank you. Thanks a lot. You really seem very unwell, actually, and then need some rest.
No, I feel great.
Yeah,
I've had
okay.
a chronic cough for about 3 weeks.
Oh, I see.
And it just won't go away. I'm not sick.
So, Ashish, yeah.
Yeah, thank you. Thank you very much. I have nothing more to ask. Great.
Thanks. Subodh?
Yeah, Dr. Rijita is there. She wants to ask any question.
Yeah, a wonderful presentation, Dr. Schwartz. Yeah, I just wanted to know, like Dr. Sankla was saying about chondromas. So is it more easier to take out chondromas rather than soft tumors? Like you showed large trigeminal.
When you say chondroma, you mean chordomas?
Yeah, chordomas, like they are little form and then bony. So the field is widened, exposure is good, you can drill the thing. And is it more easier than the other soft tumors?
No, well, soft tumors are always
especially the cavernous regions. And
soft tumors are always easier. Chordomas usually have part of it that's soft and part of it that's very firm and fibrous. Sometimes they're all soft, which is great, but sometimes they're very fibrous, the chordomas. They also tend to sort of find their way into little crevices. So you really have to be diligent. They have little tentacles that go off into little areas. You have to chase all of those down, and then they can invade into the muscle, the bone. You have to chase that down as well. So I find chordomas, big chordomas are very challenging.
Right.
They're very firm fibers. The good news is most of them tend to be extradural. Part that's intradural is usually not as big as the extradural part. So it allows you to be a little more aggressive with that extradural tumor because you can't hurt. There's not as much new things you can damage.
Yeah. Thanks. Thank you so much.
Thank
Welcome.
you, Professor Schwartz. It was nice listening to your presentation.
You're welcome. Thank you for having me. Really appreciate it.
Thank you very much, sir.
Take care.
So,
Thank you, sir. Thank you, sir.
Yeah, we will continue with our next topic by Professor Dandapani. And he will be talking of pituitary tumors invading into cavernous sinus. Professor Dandapani is a professor at PGI Chandigarh, and his lot of endoscopic works he is doing and publishing also. We regularly get to see his updates. Over to you, Professor Dandapani.
Thank you, Dr. Subodh, sir. First, I would like to thank our keynote speakers, Professor Prabhakaran and Professor Schwartz, for enlightening us beautifully with kind of describing the approaches to cavernous sinus. I would like to share our experience on managing pituitary adenomas with cavernous sinus invasion and the strategies which we can adopt. Hope you can see my slides. Cavernous sinus is neither a sinus nor cavernous, but during surgery, it behaves sometimes like a one cavity when the tumor expands it, or sometimes with multiple loculations, and it's a kind of like, it means there are various different descriptions in literature. And in pituitary adenomas, the criteria for cavernous sinus invasion has been initially very arbitrary, and various criteria had been discussed: percentage encasement of ICA, venous compartment obliteration. But recently, NOSP-MICO, they made it clear that the grading, NOSP grading, has become the standard classification for pituitary adenomas to describe the extent of cavernous sinus invasion. Sometime back, under Professor Schwartz, we did a meta-analysis, and we noted that among various criteria, NOSP grade 3-4 seems to be the best criteria for identifying cavernous sinus invasion. And we also noted that the more experience a surgeon gains, there is a higher likelihood of gross total resection. And the superiority of endonasal endoscopy over microscopy is marked in tumors which are invasive, like the ones with cavernous sinus invasion or other extensions. And sometime back, when we did analysis of our data using navigation and angled endoscope, we noted that cavernous sinus invasion had a significant impact on the extent of resection. But when we are using neuronavigation and angled endoscope aggressively, we are able to decrease that impact. In fact, that the use of navigation finally turned out to be the greatest impact on the extent of resection in our series, in which some cases we did without navigation and some with navigation. So there are various descriptions of how to enter the cavernous sinus. The one most important thing we need to realize is that the medial wall of cavernous sinus, there is only one layer, but in other places there are 2 layers of dura. So if we want to enter cavernous sinus, either we can enter from medially, or we can enter from antero-inferiorly, or we can enter from superolaterally through transpterygoid approaches. The different compartments of cavernous sinus has been kind of elucidated by Fernandez Miranda et al. And they divided cavernous sinus for endonasal surgeons into 4 compartments. And recently, Yang et al., they described the various approaches for various compartments of cavernous sinus, and they described the medial axis, anterior axis, and superolateral axis, depending upon the relationship of the tumor in relation to the horizontal segment of the cavernous carotid artery. And various techniques have been described. So in our personal series, we have 90 cases with NOSP grade more than 3, and we have gross total resection rates of 65% and near total resection of 17%. And endocrine remission in functioning tumors, it's around 50%. We have given radiosurgery for around 7% of our tumors, and with pituitary tumors with cavernous sinus invasion, and IMRT in the rest. We usually use angled endoscopes aggressively whenever there is a lateral extension, and all cases we use navigation and wide exposure depending upon the lesion, binostril, two-hand, bimanual dissection. And we have classified our strategy into various types: medial exploration and antero-inferior exploration and lateral. And I will just show few videos to elucidate. This is a medial axis, and we call it a kind of closed approach, in which the cavernous sinus, it is closed and lots of loculations are there. With every loculation, we need to enter manually by opening the medial wall of the cavernous sinus and then curate out the tumor which has invaded into the cavernous sinus. Though sometimes the tumor makes a big hole, but in certain situations, the holes are very small. Through small holes, the tumor might have invaded into the cavernous sinus, and there may be a large chunk. So we'll have to open up all the loculations of cavernous sinus and expose all the various compartments. Now we are looking at the superior compartment of cavernous sinus. In fact, superior compartment is the commonest compartment to be involved in pituitary tumors, and which is the relatively the most easiest. Now we are getting into the inferior compartment by getting lower, inferior to the horizontal segment of cavernous carotid artery. So with each loculation, when we open, we can aggressively remove the tumors and curate it out, depending upon the radiology and depending upon the need. We prefer not to go too much lateral in compared to the carotid artery. Whatever comes out medially, we try to curate it out, and then whatever remains, we give gamma knife. And sometimes we have an open type of cavernous sinus exploration, in which the tumor itself has created a big corridor. As you can see, that this is the vertical segment of the, and this is the posterior genu, this is the horizontal segment, and now we are removing tumor from the superior compartment. And the superior compartment, we'll have to gently peel the tumor out of the roof of the cavernous sinus, and because this provides the direct angulation. And once we remove tumor from the superior angle, from the superior compartment, then we can go to the posterior compartment. Posterior compartment, we can encounter Gulfar segment of the abducens nerve. And once we remove the tumor in the superior and the posterior segments, then we go into the inferior and then lateral. This is the sixth nerve, which is lateral to the carotid artery. This nerve is within the cavernous sinus, so we have to be careful not to injure this nerve. So this is the pre-op and post-op of this patient. This patient had a refractory prolactinoma, which we needed to operate. And sometimes we go antero-inferior cavernous sinus exploration. So in this case, the tumor was getting too much into the cavernous sinus. And as you can see, this is the diaphragma celling, and this is the hole which it has made onto the supracellular part little bit. And this is the cavernous sinus which we have opened antero-inferiorly. And we open it, make the cavity big, and gently curate out the tumor gradually. And whenever there is extensive venous bleeding, we use Surgiflow or Flow-C, and then we wash the cavity with saline, and then we pack it with fat covered with Surgicel. We always explore the cavernous sinus first before getting into the supracellular compartment. This is the supracellular after the decompression. This is the cavernous sinus part, and this is the supracellular part. So this is at the end of surgery. So This is the pre-op and post-op of this patient. Sometimes patients come with giant tumors with giant supracellular extension. So in these tumors, as I have already mentioned, the inferior part should be decompressed first, followed by the cavernous sinus portions, and then the supracellular portions. Because the moment you start removing the supracellular portion first, the diaphragm descends and it blocks your view. It becomes very difficult to get into the cavernous sinus. We will have to use angled endoscope extensively. When we are operating on the left cavernous sinus, we'll have to turn the angle in such a way we can look at the superior and then the lateral compartments depending upon the extent of the tumor. So once we remove both cavernous sinus compartments, the parts which are in the both cavernous sinus, then we can try to remove the midline and the supracellular portion. Because then once the diaphragm descends, then the cavernous sinus entry becomes little difficult. So this is the post-operative scan of this patient. It's almost a kind of gross total resection. And this is another patient. I wouldn't show the video fully. But again, the most important aspect is that cavernous sinus portions, so much of the portion can be removed by medial approach alone. Very rarely we try to get into the lateral compartments and from the superolateral approach. Because of the sixth nerve, most of the tumors are soft. Most can be removed from the medial compartment or sometimes anterior compartment. As you can see, this is NOSP grade 4 tumor, which has totally encased the cavernous carotid artery. This is the post-operative scan of this patient. These are some of the other kind of tumors. So this tumor, when it goes into subfrontally, again, this portion should be removed last once we remove the lateral portion in the cavernous sinus. These are some of the other. This tumor is the one which has gone through the roof of the cavernous sinus in the oculomotor triangle in the cavernous sinus. These are some of the other patients. And these are some of the very supergiant pituitary tumors. In this, sometimes we may not be able to achieve a gross total resection, but as much maximal safe surgical resection can be achieved with this surgical technique. Sometimes we can leave a bit of the tumor laterally when the tumor is very firm, and we can give radiosurgery. But whenever possible, we should try to aggressively remove the pituitary tumors, because most can be removed. In our personal experience, around 67% we can achieve a gross total resection. Though there are challenges, but I think we can kind of gradually improve our results as more and more cases we operate. Thank you.
Thank you, Dr. Dandapani. We'll take some more questions, but do we have Dr. Janakiraman's talk? Or
Yes, sir. He had sent a recorded video. I can play from my screen, and I can share the screen.
Yeah.
Yes, I think let us finish with that, and then we'll have the questions.
Yes. Okay. Please play it, Dandapani.
Good morning to all of you. I first of all thank the organizers for giving me this opportunity to share my experiences on internal carotid artery injury management and how to avoid it in the cavernous sinus, the cavernous ICA. So we will share the screen now. So my topic is dealing with the ICA in the cavernous sinus. So how do we approach a tumor which is lateral to the internal carotid artery. And we'll be showing some scenarios of what we do in our center, and then a few cases where we had injuries and what are the carry home messages we get from that. The time given to me is around 12 minutes. So I will try to cover the topic as much as possible. Now we will go to the cases straight away without going about the theory. This patient presented with a history of headache and sixth nerve palsy, and let us see what the MRI shows. So patient was operated twice for a pituitary macroadenoma, and a gamma knife therapy was given, and she desperately wanted to have the complete tumor out of her body. So MRI was done, and in the cellar. So twice operated already. Lesion was very, very fibrous. So with the MRI, we can fairly tell whether the lesion is fibrous or suckable. You can see the uniform enhancement is called a potato tumor. So that I call that. So you see the carotid artery is going far lateral to the carotid. So how do we approach such a tumor? And that's what we're going to discuss now, and how we deal with the internal carotid artery in such cases. Now here is the carotid, cavernous carotid is here, and almost in the middle of the tumor, and that's the paraclival carotid. Now let us see what we did. That's the exposure we gave. You see here, so that's the V2 and that's the VDN. And now I've exposed it through a transmaxillary transpterygoid approach, and I'm going across the dura using an acoustic knife to cut it. You see how the tumor is so fibrous. And once we do that, this is what we did. So we have actually removed the tumor from the cavernous sinus. The internal carotid artery is right in the middle. That's a cellular component which has been removed, and that's a carotid artery. And these are the kind of tumors we should be careful about when we deal with internal carotid artery, the cavernous segment of the internal carotid artery. Now let's go to yet another case. Look at this case. So it's a huge tumor again a pituitary macroadenoma, and again a revision. So most of the cases which come to our center are all revisions, and they go far laterally into the temporal lobe and presenting with cranial nerve palsies. So that's the exposure I've given, outside appearance, and then we do transcellular, transtubercular, transplanar, and then also a transpterygoid approach. So that's the outside appearance, and we are drilling. You see, there's no anatomy at all. That's a revision case, and what we have done now is this is what we have done. You can see that I'm now transposing this carotid artery. See how we go lateral to the carotid, and then we go around the carotid. So that's the kind of dissection we will have to do, transpose the carotid anteriorly, medially, laterally, and finally we cover it with a dart flap. Now let us see another tumor. Now this is a case of a cavernoma in the cavernous sinus. I operated this in Hanoi, and you can see that's the tumor in the cavernous sinus, actually going far laterally into the cavernous sinus. Of course, we did an endoscopic approach. And you see what we did was we opened up through a transpterygoid approach, and we are now dissecting. That's the carotid artery. You can see that's the carotid artery. It was going lateral to the carotid. And this is another case. Of course, we removed that tumor completely. And you see here, this is another very, very interesting case of a 10th revision of a angiofibroma. You see how it was so fibrous, and it was engulfing the carotid 360 degrees. You see here, that's a carotid artery, the cavernous carotid, and this tumor is engulfing it like a cauliflower all around and completely fibrous. So I had to use a knife to cut across and be very careful about the carotid. Such cases we do a BOT, balloon occlusion test, and if we see whether we can sacrifice the carotid. Of course, I didn't coil the carotid in this case. Nowadays what we're doing is putting 2 coils if the patient passes a BOT, and then resecting the carotid along with such a tumor. So but in this case, this was done around I think 13 years back, and you can see that we are now dissecting the carotid from the tumor from the carotid, and you can see that's the carotid. So beautifully seen the cavernous carotid, the cranial nerves running on the lateral wall of the cavernous sinus. So just wanted to show you the kind of dissections we do, and our center is, we also written a book on cavernous sinus lesions. You can go through that book. Now, I'm now going to the part where I have injured. So we have had around 4 injuries. We did a multi-center trial and also presented it in a paper which has been published in JAMA. And this is the first case in which I had an injury. See, the most important carry-home message here is don't use a punch on the carotid canal. That's very dangerous. And see that I used a debrider, the drill, which is a coarse diamond. So you can see that's the injury which I had, and we had to sacrifice the carotid. Of course, the patient was alive after the surgery. So all the 4 cases have been reported in literature, been published in JAMA. Now, this is another case of a 4-year-old child who presented to us with a tumor. And you can see that's a tumor, very huge tumor. That was actually a pilocytic astrocytoma. And this patient had a perforator from the carotid going inside the tumor. So that's what I'm drilling. I'm drilling the medial opticocarotid recess. And once I do that, I'm now elevating the dura, endosteal layer of dura. And the tumor was very fibrous. And you can see here, what I did was I'm trying to use the QSAR. No, it's not QSARable. That's a stalk, which I identified. That's the level of the dorsum sellae. And then the tumor was very fibrous. And now here you can see that's the 3rd nerve, which I'm delineating. And after that, now here is where the perforator was actually traumatized. See that's a perforator injury. Of course, we could manage this with a big plug of muscle. So what we do is don't panic, be calm. Try to take a muscle from the thigh, quadriceps, and then keep it right over the area of bleeding. You can see that now I've kept the muscle there and it actually stopped. After that, in fact, in this case, we closed the case and then we shifted the patient to an interventional radiology suite. And in fact, it was coiled. And this patient again underwent surgery to remove the residual tumor. So you can see that's the muscle being kept along with a little Surgicel. It sometimes acts very well, and can't say in all cases, but then this is another case of injury which we had. Patient was operated 9 times. No anatomy. It's a case of an angiofibroma involving the cavernous carotid artery. And what we did was it was already irradiated. And there's a layer of endosteum which is covering the superior orbital fissure. And so I used the scissors to cut that. See what I did. And this is actually the cut, the first cut, the second cut. Actually, that is a carotid injury. And once I did it, I had to, use the muzzle to plug it. Initially, I used the gauze and then the muzzle. But in fact, this patient, we shifted to the radiology suite, but developed a massive MCA infarct, and he succumbed to the injury after 14 days of surgery. So that surgery flow being used. So this is just to show you that never use sharp instruments if the anatomy is not very clear. So don't use punch forceps, don't use cutting burrs. So these are the carry-home messages I want to tell within these 12 minutes of the talk. The carry-home message is use Doppler or a navigation to map the carotid. Know your anatomy very well. Do a lot of carotid dissections before venturing on to cavernous sinus surgery. Don't use punches on the carotid canal. Don't use coarse diamond burr or a cutting burr. Study the perforators which go into the tumor before you enter into the surgical theater. If tumor is very firm, better to leave it than to produce a carotid injury. So in the era of COVID, I think we'll all join hands to fight this dreaded disease, and also the aftermath of this disease, that's mucormycosis. And we're doing a lot of cases of mucormycosis, in fact, involving the carotid as well. And I thank again the organizers for giving me this opportunity. And let me stop sharing the screen. So thank you very much, and bye-bye.
Yeah. Thank you. It's open for discussion, question, answers. Dr. Narayanan is also there, I think.
Thank you.
Yeah. So to the panelist, Professor Ashish.
Yeah, I mean, I enjoyed the last talk. That is something for everybody to learn, actually. And let me add a bit of spice to the whole situation. It was only yesterday I injured a carotid artery while taking off a
Dr. Narayanan, what about your opinion about adjuvant therapies in residual tumors? Do you be very aggressive in these tumors, or you would like to leave something and go for any adjuvant therapy?
What Vicky and I do, Vicky is the neurosurgeon I work with. Usually the tumor does most of the dissection on its own. So we usually just follow the tumor itself, and we will not do carotid dissection like the way Janaki Ram does. We will work around the artery itself, but we will not mobilize the carotid artery like the way he does. We will just follow the tumor, and most of the time the tumor does the dissection quite nicely, and we are able to remove the tumor quite nicely. In that way, you can avoid literally most of the injuries to the carotid artery as long as you respect the carotid artery. So whatever that doesn't come out easily, we'll always leave behind and give gamma knife. And we've got a quite established radiosurgery, and that responds very well with us. There's no point trying to be a hero. You can do 1,000 beautiful cases. You just take one case with a massive medical legal suit to destroy your whole career. And that is one take-home message I would like to tell all the younger ones. It's nice to see all these wonderful videos. You get one complication, you won't sleep for a few days, and one medical legal case is enough to destroy your life. So please do be safe. That's all I can say.
Very, very well said. Very well said.
And do more of cadaver dissections before you actually enter into these cavernous spaces. I think everyone agrees with that. That nowadays, with more and more workshops, we have ample opportunity to learn more and know about the cavernous sinus, especially the endoscopic surgeries. And
I think the other thing that I would like to emphasize is I think that it should always be a teamwork between the ENT and the neurosurgery. It should always be. And Vicky, the neurosurgeon I work with, we've been operating together for many years now. So he will never do anything inside the nose without me. And once I expose the dura for him, I do both lateral skull base and endoscopic skull base. So I will expose everything for him, but I will never cut the dura I will never go intradural unless he's next to me. It's just a simple matter of respect. And because of that, I didn't have time to show all the videos. I showed some of the videos, and we have progressed more and more and more because of the respect for boundary. A simple case scenario for the ENT is like, we would never be happy if a maxillofacial surgeon does a cochlear implant. We will never accept it if a maxillofacial surgeon does a FES. So in the same way, I think we should give the same respect to the neurosurgeons. And all the complications in skull-based surgery are neurosurgical. So if we do, we have a complication, the neurosurgeons are going to manage. And I think they carry a huge responsibility compared to the ENT guys. And if I had a tumor and I wanted it to be removed, I would want the ENT is very comfortable with his part, and I want a neurosurgeon who's very comfortable in the intracranial part to move together. I wouldn't want an occasional surgeon to do the surgery. That's the way I look at it. And I think that's a good take-home message for the younger ones.
Sir, that is a very wonderful message which Dr. Prabhakaran sir had given. I think we we also operate on most of our cases with Dr. Rijunita ma'am, and means our team also kind of most of the means maybe small pituitary tumors whenever she is not available, we operate ourselves. But most of the complex cases we work as a team, and because of that we are able to do gradually more and more, because one person should be there to stop you. Don't do more than this enough. I think that balance is very much important, that both surgeons should not be aggressive. One surgeon should be aggressive and one should be moderate, so that he should say that enough, bas band karo. I think that is a very important thing.
Yeah, very well said.
Yes, that's very well
Yeah.
said.
I think I would just like to add one point, that when it is a recurrent lesion, whether once or twice or whatever it is, that becomes a difficult case, and you have to really study and identify the structures extremely well, which was well pointed out in the last talk. And there the anatomy is so distorted that it is very easy, without your understanding, you might land up into unknown territories which are not desirable, and you can land into complications. And of course, if you have a vascular injury, that's a major thing, or a nerve injury, that's a major thing. So recurrent tumors, whether it's a chordoma, I've operated on chordoma in a patient 4 times. And every time I've gone in, it will go in a different area. I remove one area and then it will go in a different area, like that. So, and every time the anatomy is so different that you are very easy to get lost. And neuronavigation in that situation, all these skull-based lesions, the advantage for us is that they don't move. Like other lesions in the parenchyma, they can have a brain shift, but skull-based lesions, fortunately, don't move. So neuronavigation is a must. And of course, a Doppler is a must. So these two are very important tools, which I feel, and that is a must 100% when I am going for a recurrent case. That's something I would all emphasize.
Thank you very much. I think we are coming to the close of this session. Anyone else has anything to comment or ask? Professor Sankla, Dr. Rijunita?
Just one comment for Professor Prabhakaran. Prabha, thank you very much for joining this,
My pleasure.
this webinar and being with us today. I really enjoyed your talk very much, and we didn't get much to really discuss about it. But in the end, I'll just ask you one question. In cavernous sinus lesions, now that we are doing endonasally, many of these. Okay, what are the lesions which are confined to the cavernous sinus, and yet you want to go through the conventional skull-based approaches? What are those lesions if you do that? Can you just elaborate? Yeah.
That's a wonderful question. So the decision for the approach that we take is always done by Vicky, because he's the main neurosurgeon.
Mm-hmm.
But he'll always send me the video clip, and ask me, can I expose it for him? Is it possible for us to do to the nose? And the way I look at it is very simple. Just follow the lump, follow the swelling. If the tumor bulges into a pneumatized sinonasal cavity, which means the tumor is inside the cavernous sinus that is bulging medially, which means the nerves are lateral, then we will go endoscopically. So it's just a matter of the orientation of the carotid artery and where the nerves are and where the bulge is. If the tumor is actually bulging lateral to the nerves, then there is no window and the sphenoid sinus is not pneumatized, then we cannot go into the nose. So that's the way I look at it. I mean, life is complicated enough, so let's keep surgery simple. Follow the bump, see where the artery is, where the nerve is, and life is very easy.
Yeah.
Wonderfully said. Wonderfully. Thank you very much. Yes.
Yeah,
My pleasure. Thank you.
definitely. I just wanted to ask Dr. Raju one question to Dr. Prepa.
Yeah.
Dr. Prepa, have you ever decided, like with your neurosurgeon, that you have to, if some tumor is there, lateral to the carotid? So have you ever planned, because many times we plan our tumors going laterally, so going through transpterygoid approach, so you decide in advance before doing surgery that you should open transpsychoid. We had opened in 2 cases. I think we didn't require. Mainly if the tumor is soft, then you don't need it. I think you can go ahead and laterally, superiorly, you can remove the tumor superiorly part.
Yes.
But laterally, have you ever planned and then it was not needed? And what is your experience with transpsychoid?
That's a very good question. The last few cases that I wanted to show before, but my time was up, was cases that we did like
because
that.
I know you are very good in transpsychoid. I have seen your dissections under Chicago. You remember?
Thank you very much. Yes. So again, it's the same concept. I just look at where the lesion is. So again, if the lesion is lateral to the carotid artery and is bulging into a pneumatized sphenoid with a lateral recess, then we will do a transpsychoid. So I always find that the combination of a neurosurgeon and an ENT surgeon who plans it together works very well. For the man with a hammer, everything looks like the nail, they say. So it takes some time and experience before you know when to say no. In your career, you want to do everything. Then you get a few knocks on your head. God will knock on your head a few times to say that it's not going to work. So now I keep it very simple. A pneumatized sphenoid sinus, the tumor must be, the bulge must be obvious. There must be enough space lateral to the ICA, and the nerves must be pushed away. Those are perfect cases for this. And with an IGS, you can precisely open only the area that is required. So far with the planning we have done, we've been managed to do. The only one more thing that I can add, if I have some time, is that one of the things that over time that I do for Wiki is that I give the entire exposure. So I give the exposure for the pituitary. I remove the entire sella. So even if it's a plenum, meningioma, or a clivus, I do the entire drilling. So Wiki only comes in when the entire dura is exposed. And because when he comes in, when everything is exposed, he's very fresh. He's had his coffee, he's had his eaten something, and he cuts the dura and the tumor comes out very fast.
Very well
I think
said.
that's very important, because if you make the neurosurgeons come in early and they start drilling with you, they are human after all. They may not look like one, but they are human after all. They also get micro tremors and all that. So if you can expose everything, all the dura, and the neuro comes in, cuts and take it out, it's very fast. So like our craniopharyngiomas, our meningiomas, we do it from less than 3 hours simply because we follow this principle.
Yes.
So the younger ones who are going to start skull-based surgery, this is what I would suggest.
Very
true. Neurosurgeons are precious. Give them the important part. You expose everything and let them only come in when the important part comes in. Open the dura and take out the tumor.
Yeah, same here. Rindapani never enters when I'm operating, He just comes after when I finishes. He get a call that I am finished and then he comes.
Then he comes.
As it is said, even God doesn't know that he's a neurosurgeon.
With this good ending and a good message for the youngsters, especially to work in team, I thank each one of you, Professor Gupta, Dr. Sankla, Dr. Narayanan, Dr. Vijinatha, Dr. Ashish, Dandapani, everyone. It was on behalf of Endoscopy Society. Thank each one of you for joining. We had around 110 to 115 attendees attending this webinar. And thank you very much. And see you again.
From my side, I would like to thank the Neuroendoscopy Society, Dr. Subodh sir, Dr. Ashish Pathak sir, Dr. Sankla sir, for giving us this opportunity. Thank you, sir.
Thank you.
Thank you so much, Dr. Sanklan, Dr. Raju, and Dr. Pathak. Thank you so much.
Bye. Bye-bye.
Bye.